not, triggers a lot of dermatologic conditions. Obviously, allergy and immune dysregulation is an entire area. Environmental toxins, we saw from Dr. Campbell how much of a role those play, and Dr. Patel, I know, speaks to that. Chronic infections can probably play a role by driving oxidative stress and chronic inflammation. We know that metabolic and hormonal dysregulation, especially sex hormones, drives a lot of dermatologic conditions. And chronic mitochondrial dysfunction, of course, is another area that when it's malfunctioning, we're going to have problems. Well, let's see. So what are the top 10 when you look at a dermatology office, who's walking in the door and what do they have wrong with them? The top 10 diagnoses seen, and I polled dermatologists by the hundreds to get this data, or I have the data anyway. Actinic keratosis is very common. That's precancerous skin lesions and skin cancers. Warts, rosacea, anti-aging, and seborrheic dermatitis. So those are what we're going to cover tonight. And then in the section 2, I'll cover alopecia, acne, pigment disorders, psoriasis, and hyperkeratotic conditions. And that represents pretty much the top 10 reasons a person walks in the door of a dermatology office. So many of these conditions, as you can see, are chronic. They rely on a lot of the processes in our body that you guys are all working with. So just proceeding on to number 1, right, our old big favorite, actinic keratosis, but this is really skin cancers. And I'm sure you have all seen patients with a chest that looks like this, or a lovely scalp that looks like this. You probably can see I have a few divots where the local surgeon has taken out some skin cancers on me. So I've done a lot of personal treatment in this area. And so actinic keratosis, what is that, right? That's sun damage, essentially. Now, actinic keratosis and superficial squamous and basal cell cancers are what we're going to talk about here. But mainly, really, we're discussing actinic keratosis as a very needed, and probably everybody that has a lot of sun damage should be doing field therapy on their highly prone areas of actinic keratosis every year or 2 or 3 years, maybe at the most. And this also rejuvenates the skin, and it also produces a much nicer looking skin. So, that's an area where kind of cosmetics and skin cancer prevention can kind of come together. And of course, many of these patients whose immune systems are malfunctioning from drivers of chronic inflammation and oxidative stress, that's why they're forming more of these cancers and having more problems. So they have all the UV damage and all this, but they have the underlying processes in their body that also make them more susceptible to it over time. So actinic keratoses are basically keratotic macules, papules, or plaques, and they mostly are plaques, resulting from intraepidermal proliferation of atypical keratinocytes in response to UV radiation. So that's the whole thing in a nutshell there. Now here's the interesting part. The statistics really are scary on this. Most actinic keratoses, or little AKs, they do not progress to squamous cells, but almost all squamous cells arise from pre-existing AKs. So if you have a squamous cell, you probably you almost for sure had an AK that preceded it, but not all AKs will become squamous cells. Now, out of the AKs that do progress to squamous, you can't tell them apart. You can't look at one and know, oh gosh, that one's super bad looking and that's most likely going to be a cancer, and another one doesn't look as bad and it may be cancerous. So it's hard to tell, even for highly trained dermatologists, to know by looking which ones are bad, which ones aren't. So you can't identify them easily. And then about 10% of AKs convert to squamous cells in healthy persons, and up to 40% or even more in immunocompromised patients. So when you see, a lot of AKs popping up or squamous cells popping up on elderly patients or immunocompromised patients or patients that you're treating for other severe chronic diseases, they probably have a higher prevalence of skin cancer based on their immune function being down and damage to their P53 gene and tumor suppression genetics. So routine exams and field therapy of AKs is a sensible and well-adopted strategy in dermatology. And you have a lot of treatment options. Some of them are easy and some of them are harder, but treatment options certainly are surgery, cryotherapy, laser surgery. Those more serious things, you want to wait till somebody's done a biopsy to determine you got a cancer. But for general AK therapy, there's no reason in the world that you can't do photodynamic therapy or treat field therapy with some common agents that are easily available and can be used very effectively to manage skin cancer risks. So, we want to encourage as many types of practitioners to work in this area as we can, because not everybody goes to a dermatologist. So what happens in this process? How do we end up with actinic keratosis? And it all starts with UV radiation. And then there's three pathways that it follows. UV radiation can directly damage membrane phospholipids, triggering an inflammatory process that ultimately results in hyperproliferation or more keratinocytes. Okay, keratinocytes are produced sort of as your body's natural sunscreen in a way to protect the inner tissues from getting over radiated. So of course, UV radiation directly causes photo damage. It causes mutations to P53 gene and other tumor suppressor genes that are related to P53, like P51. And then you have basically a failure of the natural apoptosis and the damaged cell, genomic instability, and you end up with hyperproliferation. Now, another way that UV radiation causes problems is by creating reactive oxygen species, which activates platelets and NF-kappa B and all this, and we have altered intracellular signaling, cytokine dysregulation, immunosuppression that also can relate directly to hyperproliferated illness. So there's an immune side, there's an inflammatory side, and then there's a UV radiation damage kind of at the core of the process. So managing, and this really applies also not just to skin cancers, but to aging of the skin and other skin conditions as well. So this is the important message here, is that we have an inflammatory side, we have an immune side, and we have ionizing radiation side. And this all combines together to add up to a bad situation. So now let's say we have a patient looking like this, right? And we want to know, well, what can we do for this lady's chest or this gentleman's forehead here? Now, the old kind of therapy, the very first therapy that we had that was effective for this is 5-fluorouracil, which is on the list of the NIH's most necessary 100 drugs or whatever. 5-FU is well studied, and it's a core therapy for actinic keratosis and also for treating superficial, and I say superficial, not invasive, superficial squamous or basal cell cancers can also be treated topically with 5-FU. Now, what does 5-FU do? It's very interesting, actually. A lot of people think it's just simply that 5-fluorouracil is basically a Trojan horse for uracil, and it gets in your DNA and RNA and it messes it up. That's really not how it works. 5-FU inhibits this, the primary mechanism is that it inhibits thymidylate synthase, and it is a false ligand for uracil in DNA and RNA, and it induces cellular death via interference with transcription and RNA DNA functions. It also activates the P53 gene. So P53 activation is still a big part of what 5-FU is doing. So that's important to note. The other thing is that 5-FU actually operates through its metabolites. Its metabolites are this, it gets metabolized basically phosphorylated and minor, methylated and things. And so normal metabolic processes basically occur to 5-FU that cause active metabolites to be produced that also amplify the effect of it. So, and if you really look at the whole pathway that oncologists have for 5-FU, it's much more complicated than this, but in the skin, essentially we're looking at this process. So you are going to have the thymidylate synthase is blocked, and this will actually induce more thymidylate synthase to be produced, and then you create this imbalance that causes DNA damage, and then you have direct incorporation of 5-FU and its metabolites. Oh, excuse me, I tried to scroll down in the wrong place. The metabolites are listed down here in the notes, but there are these FUTP and FDUTP, and then fluorodeoxyuridine monophosphate. So all these guys are basically working together to trigger P53 gene, so that's how 5-FU is working for skin cancers. The exact now, when you're doing this, essentially you apply skin cream twice daily for 14 to 28 days, depending on the site of therapy, and that's kind of how it goes. Very simple treatment, but patients hate it, and they put it off, and they don't want to do it, or they avoid doing it, or they'll because it makes your face red basically for a month, and you'll see how red it actually gets. It's quite severe. So we want to make this as easy and compliance friendly for patients as we can. Now, what are the compliance factors that people run into? Shockingly, 5-FU is often not covered on insurance. I don't know how that can possibly happen, but it's not. We hear this a lot, that people are paying $200 and $300 and $400 for a tube of 5-FU. So, you can use custom compounding to help reduce costs for patients and probably create a better and more friendly formulation for 5-FU. But in the end, it may not really be the drug of choice for everybody because it is a lengthy therapy, generally a lot of times not covered on insurance, and the length of the therapy is really the big complaint to the patient. Now, why is that? Because you look like this. So this is an example of 5-FU therapy, and this is not really a dramatic picture. This is a pretty mild picture, actually. But you can see that when you treat the patient over the course of time, what you see on the left will begin to look like the right, and it becomes clearly that there's something wrong when people outwardly see the patient. So a lot of dermatology is related to the fact that people are concerned with their appearance. So you end up with two, and if the treatment lasts 2 weeks, then the recovery lasts about 2 weeks. So it's a month of this. So patients don't like it a lot, but now I'm going to show you some things we can do to maybe minimize that. But you can see here what's happened in 5-FU is the field of therapy is all red because 5-FU does affect healthy cells to some degree. It just dramatically much more affects the hyperproliferative cells. So you can see here that the drug is targeting into the tissues where pathology exists, and it's darkening and reddening them, and that it's also leading to immune response. So there's still a robust immune response that comes from all this apoptosis that's occurring, and that's a big part of how 5-FU also works. So that's kind of what I'm going to say about 5-FU. That's the old school treatment. It's a good treatment. It's a solid treatment with literature behind it. But there are some other treatments available too that can do this. So we also have a very fascinating drug called Amiculamod. And Amiculamod is a toll-like 7 and toll-like 8 receptor agonist. So it operates on antigen-presenting cells where these exist, and it stimulates both your innate and your acquired arms of your immune system. So Amiculamod is, unlike 5-FU, Amiculamod is not a cytotoxic drug. You could technically eat it or something, and it will not harm you as a cytotoxic drug. It will activate your immune system, but it does not, have a systemic, cytotoxic effect. So essentially, when you rub Amiculamod onto an area of your skin, it's going to activate the toll-like receptor 8 and 7s, which are kind of go hand in hand with each other on dendritic cells, and it will also attract natural killer T cells and CD4 lymphocytes that will release interferon alpha and interferon gamma. And this stimulates the immune system dramatically. So essentially what it's doing is it's forcing your body to recognize the skin cancer as non-self. Okay, it's overriding the cancer's ability to hide, and it's basically calling the police on the cancer and saying, hey, we got a problem here. And it's directly triggering the toll-like receptor and the toll-like receptors on the dendritic cells and triggering this response. Now, because of that, it's slower to act. Believe it or not, when you start rubbing Amiculamod on and exciting these toll-like receptors, you don't get a response immediately. It takes maybe 4, 5, 6 days for a response to begin. But once the response begins, it can get very dramatic as your body attacks the disease. And I'll show you some more pictures of that. But it essentially is similar to 5-FU in the way it makes your face red, and it makes the actinic keratoses light up. They say, they use the term light up because they become very red and inflamed, and then they will eventually crust and as the skin sloughs off. Amiculamod also kills tumors from the bottom up and not the top down. So the surface or upper part of the tumor potentially could be attacked also with a, if you were treating a cancer, you could use 5-FU on the top, so to speak, and Amiculamod coming from the bottom. You can do various things like that as you learn how to use these drugs better. But essentially, Amiculamod is going to rely on your immune system, including your antigen recognition response, to cause your immune system to target the cancer cells. And this turns out to be very effective, especially for superficial cancers. It's a slower treatment. It takes 2 to 4 weeks, possibly up to 6 weeks, but it's very, very good at targeting the most pathological tissue. And as we think back to the original slides we were talking about with field therapy, as we know, about 10% of your AKs, the worst 10% roughly, of the most hyperproliferative, will become squamous cells. So, if we can target the aggressive but relatively subclinical looking lesions, then we're really doing ourselves a favor. Also, there's a policing effect, because once your immune system is amped up against these types of things, it's going to clear the field of everything. So that continues for several weeks after treatment. So one of the reasons doctors who prefer Amiculamod over 5-FU like it is because of that policing effect. They're not going to miss anything. Treatment of then the treatment is pretty simple, but you can't over apply it. You're managing the person's immune system by stimulating it, so you kind of have to drive between the white lines, not deviate to being too low and slow versus too fast and aggressive. So generally speaking, what that means is an intermittent therapy. So usually you do Amiculamod Monday, Wednesday, and Friday, not daily, but Monday, Wednesday, and Friday once a day for 4 to 6 weeks. There's another protocol that's 7 days on, 7 days off, and then repeat. So we have those protocols for you if you need them. And but they essentially that's the therapy. So rather than being daily use for 14 days, it's 7 off and 7 on, or Monday, Wednesday, Friday for 4 to 6 weeks. So you do end up probably with a longer treatment time, but you end up probably with a more thorough treatment. And not everybody wants to use chemotherapeutic agents. So this is a non-chemotherapy way of having your body cure yourself of actinic keratoses and skin cancers. And 5-FU and Amiculamod are demonstrated to be roughly equal in terms of their effectiveness. They're both it depends on what studies you look at and what exact patient populations and all you look at in the study design, but they're somewhere around 70 to 85% effective. 75 to 85% are the numbers you typically hear with Amiculamod and 5-FU. So that's kind of about as good as you can do with topical therapy. Now, what do we do with that? You can also pair it very well. A lot of people will use cryosurgery or things, other methods to treat some of the more serious looking places, and then they'll follow up with Amiculamod field therapy. So example, on my scalp, if there was a place here, you might zap that with the cryo and then do field therapy on the whole forehead or whole forehead and face. And that would really produce a very nice change in the patient's skin, as well as protecting them from cancers. So, we can also do compounding that can improve this, and I'm going to go over on this a little bit more. Now, here's how Amiculamod targets. This is interesting to see. Notice that with 5-FU, you kind of all the skin's a little bit red, and then you see the targeted areas. With Amiculamod, you see a more targeting effect. You can see that the immune system is basically, if you look, some of the like at the top 2 pictures, the picture on the right, you can see it's not very lit up, but you can see it's starting to find out where the lesions are. And you can see how those same lesions light up, and it's really hard to know which ones are going to light up. Like if you tried to look at that lady's face earlier in the process and then look at it where it's very red, it's hard to pick out what places are going to turn red. You don't really know. So that targeting effect is really, I think, a big part of this treatment. Now, why do people not like Amiculamod? Okay, sometimes people don't like it. The reason why is it's a cumbersomely packaged product. When it was originally approved, they were very concerned with systemic stimulation, and they didn't really know that much about the product. And it is a long story about who developed it and how it all happened. But the bottom line is generic Amiculamod products and brand name really also, they come in these small foil packets and they're messy. You only get a little bit of medicine. Believe it or not, in that packet, there's only 0.25 grams. So it's a fourth of a gram. If you guys who are all familiar with HRT knows, that's not even hardly enough drug to cover hardly anything. You know, it's a little bit. So patients are paying $50 copay for 3 or 6 grams of cream, and they don't like the packaging and the wasting of the medication, and it's cumbersome. The typical daily protocols are Monday, Wednesday, Friday for 6 or 8 weeks. So you might need 2 or 3 boxes of this to complete that. So on a large area, it becomes more expensive. So by using our compounding processes, we can compound versions that, you know, will give you a patient-friendly pump container, the proper amount for the area that the patient needs to treat, so they're not over or under purchasing and having to get refills or whatever. And getting all that right is a big part of the compliance aspect when you're dealing with something patients generally know they need to do, but they don't want to do. So how is Amiculamod working? Okay, it's basically stimulating both your innate and your acquired immunity. And so it stimulates toll-like receptor here. It activates the MYD88 signaling cascade, but it's essentially upregulating the activity of our old bugaboo, NF-kappa B. And then NF-kappa B goes and secretes all of its pro-inflammatory cytokines and polarizes the immune system to Th1. So it polarizes the immune system away from Th2 and to Th1, and really to Th17 also, which is not mentioned here in this literature. And then you can see here that there's a wide number of immune cells that are directly impacted by this. And the reason for that is toll-like receptors are on our cells for antigen recognition. They're involved in that. So, you know, we're basically going to our antigen recognition system and hyping it up to say, you have missed this, this invasive pathogenic disease and you need to get on it. So you can see here, we're going to activate beta cells. We're going to have our Th1 activation. We're going to have, you know, more or less inhibition of Th2 polarization. And then, but we're also going to be working through all these other different types of cells. Natural killer cells are activated. You know, your, what do they call those? Polymorphonucleocytes. Interleukin-8 will stimulate them into action. Our macrophages are stimulated. So there's a lot of this immune system stimulation, which you can see, you know, here in the patient's face. So that's what that looks like when you see this process on paper, on skin. That's what it looks like. Yeah, a very fascinating medicine that I think has a lot of other opportunities for use in cancer. And a lot of research and things have been cut off on it because, again, it was Amiculamod was owned by some drug companies that basically were smaller drug companies that bought it and sold it, and they didn't really manage the asset of their molecule very well. And so I believe it's an underutilized medicine that could be probably found a lot of other good things to do with it, including herpes. So here's some look on Amiculamod. It's you can see here again that it targets the actinic keratosis cells specifically, and you don't see much reddening or damaging to the healthy skin because it's not a chemotherapy agent. It's just only acting through the immune system. So in this case, this gentleman's bald head looks better than it did at the beginning. And this is not a very dramatic case, to be honest with you. I couldn't find a lot of, but you can see here towards the end of it, the more serious lesions that you see here. I don't know if you can see my pointer, but I'm pointing to some of the lesions that are really lit up here at the end of that are the most severe. But when you look here, you don't identify them at all as looking serious. When you see in week 1 and week 2, you don't see those as standouts. You see, yeah, I think that we have to somehow let the body find the lesions because it's hard to identify them. Now here's some more serious cases, but this is what Amiculamod can do to hyperproliferative lesions. And what you see here is crusting. And you ask, where is the treatment endpoint is a common question. How red do you have to get? And you want to see some crusting. And that applies with 5-FU, and that applies with Amiculamod. You want to treat the patient until some of these more serious looking lesions that have lit up and stepped up as the more serious ones, they crust, and they're obviously scabbed and crusting. And when you see that, you can assume that the medicine has done its job and you've eliminated that lesion. So pretty interesting stuff, but actually not that hard to do. It's a matter of applying the skin cream through every other day for 4 to 6 weeks. Now here's the guys we're looking for that we don't want to see, right? If you see any of these guys, this is what you have a biopsy done and probably send them to a Mohs surgeon unless you're a Mohs surgeon. But these are the conditions you probably don't want to treat. Whenever you see a squamous cell folding in like this, that's bad news, very bad news. And it's going to become invasive, and that's get to the doctor right away, or the surgeon, not the regular doctor. And then, same thing here. So you can see that basal cell cancer is a little harder to identify. They're not as distinct because they're in deeper tissue as opposed to a squamous. So any of this stuff that you see, that's a time to have a biopsy. But I don't want that to scare you off from being able to do basic field therapy, because I think field therapy is really important, and many more people should be getting this as a routine treatment. And if they don't see a dermatologist for any other conditions, and they're seeing you for regenerative medicine and chronic disease management, all these other things, you may be the only person that they ever see that has an opportunity to tell them this. So I was hoping that would be maybe an important message in your screening, and a business opportunity too to treat that patient. Now here's what the dermatologists really started using now. Both of those treatments, essentially you find dermatologists that are in camp A or B. They like Amiculamod or they don't, or they like 5-FU or they don't, or they kind of do 50-50. That's what you find. And published a study, this is interesting, a study was published about 2017 or 18, where some dermatologists theorized that combining 5-FU, the effect of 5-FU, and the effect of calcipotriene together might have a synergistic effect, and for sure they were right. So there's a study of a fairly small number of patients that I've quoted here that the entire dermatology profession really kind of pivoted on and accepted, and they've used now a combination of 5-FU and calcipotriene. Now, what does that do? It's very interesting. So there's a synergistic effect between calcipotriene and 5-FU because it actually ends up activating a lot more CD4 T cells. Calcipotriene induces the production of that thymic stromal lymphopoietin, which is an epithelium-derived peptide cytokine, and it induces a robust anti-tumor immunity in the skin. And so combining that effect with the 5-FU has look at what it does for the treatment protocol. Instead of 14 days to 28 days, it becomes 4 to 5 days. And so this is the gold right here, because these are the protocols I've derived from looking at many thousands of patients that were treated. So on the face, the ideal time frame is twice daily for 4 to 5 days in the face, neck, or ears. 7 days on the arms or lower leg, because they tend to be crustier or harder to treat and less vascularized. And then on the trunk of the body, you may be able to go on a heavy AKs on the back or something weird, or the lower legs. You may find that up to 10 days may be needed. But basically, 4 to 5 days on the face or the neck is a very great meaning to the patient, because now the whole entire process of treatment recovery occurs in a 2-week period or less, whereas just the treatment phase was taking 2 weeks before. So a significant reduction in the time frame and the acceptability to the patient. Now you do get real red and light up really quick on this, So you do, you will, it is dramatic and you have to be prepared for that, but it's not that bad, and it again, it clears that field of all the AKs that are likely to become that 10% that could be a squamous. So this is a really nice therapy. It's easy to do, it's inexpensive, and it pretty much has to be compounded, I guess. I don't believe there's any commercial product that combines these, although you could purchase them separately and combine them. But then you have cut the strength in half. So when you take product A and product B, and they're both 5%, when you put them together, now you have 2% of each. That's how that works. So you don't have as strong a product. Anyway, so that's what I had to say about actinic keratosis, and another really nice chronic condition that you can manage for your regenerative medicine patients that they probably have high comorbidity for because of their other chronic diseases. Now, what is the very closest friend of the skin cancer is the wart. Okay, we're talking about all the horrible guys today. So we pivot now to wart therapy, and I do that second because it really is almost the same treatment. Warts hide from the immune system by various means, and viruses and skin cancer. I think viruses and cancer share a lot of the same, or exploit a lot of the same immunologic tricks that they can use to exist inside the host, because at the end of the day, they're both something growing inside of a host. So you want to reduce the host's defenses against yourself, but you don't really want to kill the host per se, because the host is necessary for the virus, so, or the cancer. So they tend to do some of the similar things, and you'll see that here. So warts, most warts, and dermatologists hate warts, and so do podiatrists. They can be a can of worms, but they can also be really easily treated. And there's really no prescription drugs to treat them. You don't really have a good treatment option. The over-the-counter stuff, you have salicylic acid. It's not that effective. You have these kind of gimmicky freezing devices that kind of imitate cryosurgery, which you really can't do. That they may work a little bit, and there are some other therapies that work. I've heard about this thing called a wart abater, which is some kind of electronic device that kills warts, and it seems to work. But that's a whole different thing, and kind of outside the mainstream. The mainstream treatments are going to be similar to AK treatments. Immune dysregulation and chronic inflammation makes patients more likely to be infected. That's why warts spontaneously resolve for a lot of people, or for some people. Like if they get very stressed or upset, and then this upsets their immune system, and then they become susceptible to a viral infection, they get the HPV in their skin, they develop a wart, and then they mess with it, and they develop 2 or 3 more warts, and then miraculously they'll go away after 6 months. Well, what happened is their immune system finally regained its strength and caught up with it and dealt with it. But for many people, that never happens. So common treatments, or I'm sorry, the warts are caused by over 100 different strains of HPV too. This is another thing. So when you look at different warts, like a common wart, a periungual wart, a genital wart, and a really deep plantar wart, what makes them different? Why do they present so differently? Or flat warts is another example. The reason is they're caused by different strains of HPV. So different strains just basically present differently. So there's and the real 3 distinct causes or cases are plantar warts, which are separate and they're very vascularized, genital warts, which kind of have their own etiology, and then flat warts, and then common warts, of course, which you normally see. Now, some will. The other big thing about warts, why do we treat them? They are contagious. They can spread from one person to another easily, and they can also spread from you to another place on you. And whenever we see these clusters of warts, which they call quote unquote mosaic warts, what that means is that they've spread, right? So you had one wart, and then you started, and now you've got this broccoli kind of or cauliflower looking thing where you have all these nodes of warts that are kind of clustered together. Oftentimes that happens because the patient has cut it and made it bleed. So when people go after the wart and they go take the facial razor, that you shave with, and they dig on it, or they take the fingernail clippers and try to cut it out, they'll make it bleed and it will spread and it will form a cluster. So my opinion, never, if you make a wart bleed, you've probably messed up. And children will resolve them better because their immunity is better. but children are also likely to spread them. OTC treatments are slow and they require a lot of patient diligence. You got to put that compound W on that wart every day for, however many weeks or months it takes, and you can't miss any days, and you've got to really keep after it and all that. So you can get rid of warts with salicylic acid, but it's not very fast and it's not very reliable. So here's an example of a cluster of warts. This is a plantar wart, but you can see these are fairly deep, but not too bad. But this is just kind of a photo of what you're looking at. The very typical patient presents with something like this. So what are our home-based therapies that we have? I've got a real good stable of these that we've developed with dermatologists over many years. Salicylic acid 65% paste is a good starting point for a small wart. That is kind of the gold standard for OTC treatment. You can't get 65% paste OTC. You'd have to prescribe it, but that's an option. And it does work for some cases. You can amp that up a little bit with 5-FU. And the most common, probably the most common, and I think the most effective thing we have for small warts, superficial common warts or periungual warts, is the 5-FU salicylic acid paste. Now you'll hear a lot about people using stuff called wart peel, and wart peel is, I don't know if it's really a product, it's just kind of a common formulation out there, and it's a 5-FU solution and with salicylic acid, and you'll see it in different strengths from different places. Some people, I think you can buy it over the counter in Canada, or you can sell it out of your office. If you buy it from Canada, you can sell a product called wart peel in your office, and it's got I think it's 5-FU and I think 20% sal acid. The one we have is 30% sal acid. I'm not a huge fan of the solution. If you use the paste in the solution, you'll never go back to the solution. The paste is, or the solution is fine, and that's a very common item out there, and it's usually sold really cheap, like 30, 40 bucks or 50 bucks. But it's not nearly as good as the paste. The reason why is the solution does not, it has 5-FU in it, chemotherapy agent. It doesn't stay on top of the wart. It ends up treating the localized tissue around it and messing that up. So I think you're better off with the paste because it stays on the wart, and the sal acid is much stronger, and you just get a more robust effect. So I've seen the wart paste peel a wart off in just a couple of days. And you may not even be able to apply it every day because it's strong and it gets rid of them quick. So my recommendation there would be the paste, but the solution's fine, especially if you like wart peel and you want to be at the lowest possible price. Now, Amiculamod and sal acid, that's another wart treatment. And if you notice that all we've really done here is added salicylic acid to the Amiculamod, because as the wart knows the immune system attacks it, it's going to start growing as fast as it can. I don't know why, but they see that and they start growing. So when you start to have the immune system attack them, that sal acid is nice to keep dekeratinizing the top of the wart while you're also stimulating the immune system in the same manner we just discussed with AKs. But Amiculamod and 5-FU do a great job of treating warts, either one of them. Now the Wart Kit, we have developed this thing called a Wart Kit for podiatrists. Podiatrists really struggle with some of these very deep, long-term, super recalcitrant warts, and we end up having to treat them on and off by alternating all these agents. So you can alternate Amiculamod and sal acid with the salicylic acid paste, or you can alternate and you can even throw 5-FU in with the Amiculamod and do both. You don't want to do that on any healthy tissue or it'll set them on fire. But for a wart, when you have a difficult wart, we can guide you through that process. That almost deals with any recalcitrant wart that I've ever seen. Some that are still recalcitrant, there is cidofovir available. Cidofovir is, I believe it was developed during the HIV boom of antivirals, but it is very effective against HPV and can be used, but it's very costly and it's hard to find. Now, Molluscum Contagiosum sometimes come up when we talk about warts. Molluscum are not HPV warts. they're warts that are caused by pox virus. So they call them water warts. They get them on kids a lot. It's a little bump, it's a little red bump with fluid in it. And that fluid should not be drained. Obviously, that is pox virus. And generally, these resolve on their own. So in children, we usually tell people not to treat molluscum unless they're afraid that the other kids are going to get it. If you have a whole family and one child's got it, it is highly contagious, but most pediatricians don't treat it. So Molluscum Contagiosum, you would either use a low dose of Amiculamod, you would cryo them, you would use cantharidin on the individual lesions, or you just give them a little bit of sal acid cream and let them go home, and it'll work itself out over time. Children generally do not have problems with molluscum, but they can last 6 months. So you have this itchy condition under your armpit that lasts for 6 months, and I can give it to my friend. So a lot of, to treat or not to treat becomes the question, because we're usually talking about pediatric patients in this case. So, I tend not to treat them, or if I would, I'd use a very low dose of Amiculamod, or just 5-FU, or no 5-FU, and just maybe some sal acid or something to try to kind of help break them up. So that's the word on molluscum. Now, you got office-based wart therapies. A lot of doctors treat warts in their office, and there's a great way, and that's a good thing to do. Cryotherapy is the most common thing in a dermatology office that they use, but deep warts will not, you can't freeze them, they're too deep, and the patient cannot stand the pain of the cryo. So really the limit of cryotherapy is how much how deep freezing is required, and if so, can the patient withstand that pain? So children obviously aren't a great candidate for cryo. Anything that's deep or on the foot or on the hand or on the genitals or any of that, of course, you're not going to be able to cry it. So what do they do then? They use cantharidin, which is beetle juice. Remember beetle juice. Cantharidin is a brown, no, it's not brown. Cantharidin is a clear liquid that is 0.7% cantharidin, and it basically just induces a massive immune response, because this cantharidin is just a massive immune irritant, and it'll cause a blister to form. So the theory is, if the wart's pretty superficial and I put the cantharidin right on the top of it, it's going to form a blister underneath the wart that comes from the dermis and pushes the wart out, and the wart just literally peels off and falls off. Similar to cryotherapy, really, which is doing that same thing by freezing. Okay, so that's a very valid method, but again, cantharidin is dangerous. It's an office use item, and it's super hazmat. So you don't want to spill the cantharidin. Some of the worst lab accidents in the compounding pharmacy that I've ever seen involve cantharidin, and it can blind a person. It can, cause you to have an ulcer. Like if it gets on your skin, you can have an ulcerative lesion. It's very bad. So you don't want to get that on yourself, or have, or maybe have it in your office at all. Some offices aren't even allowed to have it in the building. Cantharidin, sal acid, and podophyllin is an old mixture for genital warts, and you quote unquote paint the genital warts with it. I also heard of it used like on cervical HPV cancers or warts. But podophyllin is very old school. It's a highly toxic substance, but it does work. We got laser therapies. A lot of people, laser therapies are great. It's a time consuming, it can be a costly option. I'll show you a slide on that. Candida injection. You can also inject Candida antigen. You can buy a vial of that and inject it under the wart, and sometimes that will cause the wart to peel off. And then you have your various destructive agents, such as trichloroacetic acid, DPCP. And these are literally just chemicals that just literally kill everything and dekeratinize the skin and just, macerate the wart. And some people use those. Oral cimetidine also has been noted for wart therapies because it modifies the immune system. And it might work for some people. It's worth a try. If you have somebody with a lot of recalcitrant warts, give them a week worth of cimetidine or something. It might work. It works inexplicably for some number of patients. So usually that will get tried in there if there's a recalcitrant problem. And my feeling is, what does it really hurt? It can't really hurt anybody to try it for a couple of weeks, and if it helps the warts resolve quickly, sometimes it like magically resolves them. So and I realize that's not correct, and there is a mechanism of action, but nobody really seems to know what it is. So it's just the dermatologists know that it's worth a shot in a case where, you know, there's not really much risk to do it. Now, here's what laser therapy looks like. This is actually very well done laser therapy on the foot, but you can imagine that took somebody a lot of time and probably cost the patient quite some bit of money, because you're going to get charged for each one of those extractions. And when it go wrong, here's kind of what happens here. That's an example of one that went wrong. And it becomes infected, and then you got more problems. So that's why people don't like warts, is these kind of things can really be a bugaboo. Anyway, I hope that makes you a little bit more comfortable and familiar with the treatments that you can use to treat warts in your office. So basically Amiculamod or 5-FU, and we have some nicely packaged products that you can use for that purpose if you wanted to. So moving on again, if you have any questions, please stop me if you want on warts. But moving to rosacea. Rosacea is another really common condition. Millions of people have rosacea. It's one of the most common dermatologic conditions in the US, or probably worldwide. It's a chronic skin disease involving skin barrier damage, immune dysregulation, and endotoxins. So we have pathogens on the skin producing endotoxins. We have a damaged skin barrier that doesn't keep those endotoxins away from our inner cell tissues. And then we have also an immune component of it, which is your immune system is polarized to Th17, and interleukin-6 is highly involved in rosacea, in interleukin-6. So Th17 polarization is part of your host defense against extracellular pathogens. So you're basically, I think that your body sees these endotoxins, and then that stimulates your Th17 response, particularly because Th17 exists particularly at the mucosal and epithelial barriers. So your skin is directly connected to your or directly responsive to Th17. So in your Th17 dominated illnesses, you are likely to see rosacea. Let's see, and then many rosacea patients also, believe it or not, report SIBO, right? Our friend, the gut microbiome, is highly related to rosacea etiology. SIBO tends to cause B12 deficiency, and it causes elevated pro-inflammatory cytokines, particularly, as we know, interleukin-6 and TNF-alpha, and combine that with the Th17 polarization, and there you have rosacea. Now you have 4 types: vascular, papular, what they call phymatous, and ocular. And ocular rosacea is also commonly just confused with periorbital dermatitis, which is more pollution related or like toxin related. And so you have to kind of differentiate that. That would be one thing to look at, and I can show you a little bit about that. But the main patient's complaints are, and I can't pronounce the word, but it's basically the blood vessels that are visible, telangiectasis or whatever they call that. I can't pronounce the name, I'm sorry. And I didn't write it down. But that the red blood vessels in the skin that show is particularly unsightly to patients and very disturbing to them. And it's also probably the root cause of what they call the phymatous part of rosacea, which I'll show you here. So rosacea progresses in a way from, you'll have the vascular signs, then you have the inflammatory signs, and then you have these phymatous changes. That's what the old bulbular nose and the fibrotic changes that take place over time, where the disfiguring effects can occur. So rosacea can be a disfiguring disease of the face, and so that makes it doubly important to treat it so that it doesn't progress. And fortunately, we don't see too much untreated rosacea today. It's a disease that can be treated. But the main thing is we have vascular, inflammatory, fibrotic changes that are occurring. The ocular rosacea is hard to differentiate from other forms of dermatitis. So the question is, if you put a steroid on it, that's the wrong thing to do if it's rosacea, but it would be the right thing to do if it is simple, periorbital dermatitis. So that's a differential diagnosis that we would need to learn to make. But basically, if you try it, if you see the rosacea on the face and nothing on the eyes, I would not assume that rosacea would begin to show itself on the eyes only. So I think that's probably your differential diagnosis. If the person's lit up with rosacea all over their face and their eyes are affected, probably most likely it's rosacea. So you don't use steroids in rosacea. So a little bit more about it. Now, what's going on? Okay, we end up essentially, here's what's showing us what is going on with the endotoxins. So we've set the stage. We have a susceptible patient, who has some of these propensities of chronic diseases. And then we have the age, and we have habits. There are things that trigger rosacea, which we can go into. But, and then this condition of their skin, right? If they have low water content, or what TEWL is transepidermal water loss. So what that basically means, if you have aging skin or you have dehydrated skin, then you are going to have an effect on your microbiome. And the microbiome is what kind of controls rosacea flare-ups. So you have bacteria that live on the skin, these propionobacterium, which is the guys that cause acne. We have staph, which is all over our skin, as we know. And we have these new guys called Demodex mites. And then we have our normal flora. So when we have a low normal flora and our microbiome of our natural bacteria on our skin is disrupted, then we have an overgrowth of these Demodex mites, right? These are mites. They're skin mites. They're insects by definition, but they also are so tiny that they produce their own endotoxins. They secrete polysaccharides and lipoproteins and glycolipoproteins and all this stuff. And this essentially becomes immune system triggering. Now, we also know that staph and propionobacterium in acne also can cause a lot of inflammation, and that's part of the acne process, or part of the other just soft tissue and skin infection. And they produce endotoxins. Staph and produce endotoxins, as we well know. So these endotoxins then flare up. So part of the control of the disease is to control the bacteria, to control the Demodex mites, to help improve the condition of the skin with regard to the physiological condition of the skin with regard to its health, and then look at the microbiome of the skin. So those are the areas that we're going to be working in to treat rosacea. Now, Demodex mites, what do? And these bacteria, here's how these endotoxins basically create this immune cascade of hyperinflammation and immune dysregulation. And it leads to fibrosis in the end. So what we do is we're going to trigger, I guess it makes sense that we would trigger mast cells when we have an offensive agent like the Demodex or the proteases and these inflammatory endotoxins that are produced. And this stimulates macrophages, neutrophils, and mast cells in different ways that essentially produce inflammation, angiogenesis, and fibrosis. So those are all part of the immune system's response to these endotoxins. And that's what creates in large part the disease. Okay, so moving past that, what a little bit more is going on, we can break into the immune system polarization, but without going too far down the rabbit hole of immunology, we have the Rosacea triggers, which are your bacterial proteases, your Demodexis proteases. It could be heat, stress, could be UVB. They all are going to trigger various pro-inflammatory cytokines that polarize our immune system to Th17, okay, and away from Th1 to Th17. This is what leads to the angiogenesis and the inflammation and the fibrosis. The fibrosis actually, comes from mast cells. So I misspoke there. The Th17 is what's leading to your inflammation and angiogenesis. That's the visible blood vessels, and that's no good. Okay, mast cells also participate in that process by triggering the growth factors, the VEGF, and your TNF alpha, and that also leads to angiogenesis and inflammation. So you can also see that neutrophils and macrophages play a role in all these pro-inflammatory cytokine processes. But the key one is that this Th17 dominant and interleukin 6 plays a big role in that. And we don't really have interleukin 6 on this, but I know that to be the case. So that's a little bit better slide, going a little bit deeper into it, but that gets you the the basic etiology of it. So what do you do about it? As we know, Metrogel has kind of been always the gold standard, right? Metronidazole. Well, what were we treating with metronidazole? We were looking back at this, we're treating the Propionibacterium. And metronidazole is not really very good at staph, we know that. It doesn't do anything for Demodex mites. So really all we're doing is we're killing off the bacteria so that the Demodex mites and the staph can take over. So it's not a really great therapy, but it does work for some people. Usually metronidazole is combined with a low dose of doxycycline, as that's the first line of therapy. Doxycycline does address some of the anti-inflammatory components because it does suppress interleukin-6 to some degree, but it's really not the right guy for the job. So metronidazole is one part. It controls the Propionibacterium and the anaerobic bacteria that are in there, but azelaic acid is probably better. It also polarizes the immune system away from Th17, and it helps a little bit more with the acne-like aspects of it and the redness. And ivermectin actually is also a great item for rosacea. Interesting. So we've learned a lot about ivermectin with COVID, but what is it about ivermectin that makes it effective for rosacea? Well, remember we talked about the Demodex mites. So these Demodex mites are an insect and they are killed by ivermectin. Therefore, that stops their production of endotoxin. And if we use at the same time antibacterials like azelaic acid or metronidazole, we are addressing the Propionibacterium in the staph. And then we're also helping to establish a more functional skin barrier and microbiome. So now we're starting to get somewhere with our therapy, right? So now what are we talking about? We're talking about azelaic acid, metronidazole, and ivermectin. And this is conveniently called triple rosacea cream. And it's very popular in dermatology. And really people outside of dermatology do not even know about it. But it's a kind of a one treatment, one shot deal for rosacea. And it works very, very well. It doesn't always address 100% of the concerns of the patient, because sometimes the patient's main concern is a flare-up, and you've not treated them before. They walk in the office, they're red and inflamed, and they're upset. In that case, you can use one of two commercial products, or you have compounding options. There's a product called Rofade, which is the better of the two. It's oxymetazoline 1% cream, a stiff dose. And remember, oxymetazoline and brimonidine are both alpha agonists, so they are causing vasoconstriction of the blood vessels. Brimonidine is a strong alpha, I believe, alpha-1 agonist, and it's too strong for most patients. It's a profound vasoconstrictor. So we found that this is a little bit too strong for most patients. Oxymetazoline then came out a few years later, and it's been better, and it doesn't really seem to cause a lot of rebound. And it's about the right strength, you know what I mean? It is a mixed agonist. It is not only a pure alpha-1, it's a alpha-1, alpha-2, so it's doing a little bit less at the key receptor, and it just seems to be in the right zone as far as potency goes for the best effect without further side effects. We don't want people to be pale looking because we've cut off all their circulation in their skin, right? It doesn't sound like a good idea. So a mild reduction in or a mild vasoconstrictive effect's great, but a profound one just doesn't strike me as healthy for any reason. So the two components that you need probably are a topical that addresses the all of the etiology, but then you need a separate thing that has the redness reducer in it, because you don't want the redness reducer just to use every day, need it or not, all that kind of stuff. It's really not appropriate to combine those two therapies, I don't think. So that is rosacea in a nutshell. So yep, triple rosacea cream, really, really good idea if you got rosacea. And again, that could be compounded for 50 to 60 bucks for a couple months supply. The patient's happy, works pretty good. So any questions about rosacea? Well, we're stopping, I can do that now. And if not, we can do that at the end too. All right, I'll move on to my last subject for the evening, I think. Or no, I have two more. One is cosmetics and anti-aging therapies. Okay, let's run through this real quick. the anti-aging and cosmetic dermatology markets are huge, and there's a giant opportunity there, but there's a risk of crossing over into fads and unnecessarily cosmetic therapies that desperate patients will pay for. And this is a slippery slope that requires the physician's judgment to step in and say, you know, Mrs. Jones, your lips really don't need to be 4 times the size they are. You look very fine. You know, could we think about other options? So that's one aspect of when we get into anti-aging and some of the treatments surrounding it and the appearance related stuff. Board certified dermatologists are very cautious about product claims in the area of anti-aging, and their literature does exist, but they really only go with their literature. And this is an area I think where regenerative medicine doctors can really bring a lot more to the table, because you can provide systemic therapies that are good for anti-aging that also benefit the skin. And then, you know, the topicals can remain pretty simple. So in derm literature, what do you see? You see retinoids, you see vitamin C, vitamin E, alpha hydroxy acid, which is like glycolic acid. You see CoQ10, you see ECGC, hyaluronic acid, niacinamide, and ceramides. So we're going to basically combine all of those and come up with some good anti-aging therapies. The other big thing about anti-aging is that there's a dysfunction in what's called NMF, or your skin barrier. NMF means your natural moisturizing factor. What that is basically this goo or sebum or oils that your body makes by breaking down squamous cells and recycling them. So when you break down the skin and recycle it, those oils are then repurposed as to become your NMF. And that has a lot of interesting recycled chemicals in it that you see from the, and then you have the skin microbiome, which I guess horrifically is feeding all of this. So it literally eats the NMF. So all this stuff's necessary to work together to have healthy skin. So regenerative medicine, I do believe that the people here, all of you, can really come up with some interesting ideas to address some of these things. So, and I quote a nice article here on skin barrier just as something to look at. So what are we gonna, whoops, I got a bad slide here. I'm gonna delete it. Let's see, there we go. So, all right. Pardon for the delay. Okay, so what is the AAD, the American Academy of Dermatology? What do they say about anti-aging? They say protect your sun every day, protect your skin with a sunscreen, don't tan, don't smoke, don't avoid repetitive facial expressions, eat a healthy, well-balanced diet, drink less alcohol, exercise, clean your skin gently as not to, you know, physically harm it, wash your face twice a day and after heavy sweating, apply a moisturizer, and use skincare, and don't use any products that sting or burn. Now that's pretty basic advice, and I think a lot of it coincides with what we're all telling people, right? Use a sunscreen, don't tan, and avoid. So what are you doing? You're protecting yourself from UV radiation that creates free radicals and drives chronic inflammation. Smoking, of course, drives free radicals and chronic inflammation and causes vasoconstriction in capillary beds. So all these things are all bad for every condition, not just the skin, is my point. So they're not really giving you that much here to do, you know, that you don't already know. Now in menopause, they go on to say menopause triggers many skin conditions that treated symptomatically, or that get treated symptomatically, while the underlying hormonal condition is not treated. This is one of my main points that I'm trying to make, is there are things that regenerative medicine doctors treat that highly impact dermatology that dermatologists do not treat. So there needs to be a partnership formed there, where if menopause triggers many skin conditions, why not treat the underlying hormonal imbalances? And I realize that's not their expertise, but certainly it is the expertise of many of you guys. So you could either treat the dermatology conditions as well, or you could partner with somebody that treated dermatology and do their hormones and probably do their service, their practice, a great service. Female sex hormones decrease in menopause. Skin can become drier and thinner, leading to wrinkles and other appearance altering effects. Relative androgen dominance leads to increased facial hair and thinning hair on the scalp. So that's alopecia and facial hair in women. Low estrogen, especially with high sun exposure, leads to pigment disorders because pigment is operated in part by estrogen. These all directly affect people's appearance and are highly sought after therapies that we can discuss further, because we are going to go over pigment disorders at another time. So the AAD recommends sunscreen, annual screening, mild cleansers, skin rejuvenation procedures, and avoid any drying treatments for any conditions that you already have, like rosacea, and expect more bruising, slower healing, and the possible of increased instant sensitivity to irritants, and no tanning and no sunscreen and no sun. So microcirculation is reduced, skin barriers become less effective, less collagen synthesis and less cellular regeneration and hormonal balances lead to most of this. So my question is, regenerative medicine can help with a lot of these things. And these are all right from the AAD website. AAD advice on product selection. Use one product, don't use 10, because that way if there's a problem, you don't know what caused it. Test the product before applying it. Stop using products if they hurt you. Follow directions. You know, some products are going to counteract with each other, so don't use the wrong product at the wrong time. This is such basic advice. And so I think what I'm trying to show here is they're not really looking at the root causes of the diseases and explaining that. They're just kind of looking at practical things that people can do. And I think that's the area where, you know, the regenerative medicine doctors can help deepen the systemic aspects of dermatology therapy. So what are they harping on all the time, basically, is don't get exposed to UV light, right? Don't damage your endothelial health with smoking or whatever. Keep your skin moist so it functions. We're going to see why that's such a big deal. And then, you know, develop a daily routine that maintains all this. So, molecular mechanisms of dermal aging and anti-aging approaches. This is a nice study. It basically says the dermis is composed of mainly of extracellular matrix. So most of what you see in your dermis is not like cells, it's just extracellular matrix. And then fibroblasts are in this as well. And we're going to talk about that because fibroblast activity is a big part of aging. The ECM is mainly made up of collagen, and fibroblasts are differentiated from mesenchymal cells, and they live in if you envision it like fibrin ropes or fibrin strands, elastin and fibrin, they make a network. And then within that network, the collagen kind of attaches to it. So you have it's sort of like the elastin and the proteins are like rebar, and the ECM collagen is like the concrete. So you're combining the concrete and a rebar to get a stronger product. Okay, that's essentially what your dermis is doing. And so with aging, the collagen production is reduced. And so when the collagen is reduced, that means just like taking the concrete away and leaving only the rebar and some of the concrete exposed. Now the fibroblasts are the guys that are secreting a lot of this stuff. So the ECM being made by the fibroblasts attach to the fibrin network. And then when the fibrin network becomes physically distorted, the fibroblasts themselves become disconnected from it, and then they atrophy and die. So fibroblasts are downregulated basically by the process of aging. So all three layers of your skin, your epidermis, your dermis, and your subcutaneous tissue all undergo degeneration with aging. But the dermis is most obvious because your extracellular matrix goes away and your collagen goes away, and that destroys your fibroblasts. And when that's destroyed, you can't make any more collagen, you can't make any more elastin and all that stuff. So you lose your ability to make it. So it's a vicious cycle. So intrinsic aging occurs naturally and mainly causes fine wrinkles in the epidermis. But extrinsic aging from sun damage is mainly, that's the deeper, more serious problems. And so you can see how it all kind of adds up into a problem here. And we'll take a little further. The effect of aging on the dermis is essentially driven by reactive oxygen species that are triggering MAP kinase and NF-kappa B indirectly or directly. And then at the end of the day, the sun and aging increase oxidants. They trigger NF-kappa B and pro-inflammatory cytokines. This directly dysregulates your collagen management and your ECM and your dermis. It leads to collagen degradation. Fibrin networks are also degraded. And as this whole network degrades, the fibroblasts are stressed. And then what do? They become senescent, and they start pushing out free radicals. So when that happens, of course, that further damages the whole process and everything goes downhill. So that's the process at hand. So what do we do about it? What are our goals of treatment? To increase collagen production and prevent destruction, to increase the elastin fiber network, and then to bolster fibroblasts, to buffer the ROS signaling, to reduce activation of inflammatory cytokines, to prevent UV exposure and ROS formation and genetic damage of P53, and then which is our tumor suppression system, and then increase cell cycle speed. Because when we do that, we're going to cause the whole process to make more collagen. Because when the epidermal cells exfoliate, they trigger more proliferation of these things in the ECM. So those are our goals of treatment. So now what really works for anti-aging in the human skin, right? What can we really do about it? So here are our actors and our drugs, and from our drugs we can create our protocol. So we want retinoic acid or some retinoid. Okay, retinoids are well studied to show that they will basically increase all three types of collagen. It will decrease these negative proteins, it reorganizes the elastin fibers, and it normalizes what they call gag disposition, which is another negative process that impairs collagen production. So basically, tretinoin or retin-A works to improve your skin by many, many factors that are all mediated through the retinoid receptors. Retinoids have their own receptors, the RAR and the RXR receptor, but they basically stimulate collagen production and they stimulate sloughing off of the epidermal layer, and it causes all this really good effects in the ECM. So that's what we're looking for. Now, another process we talked about was we need to quench free radicals. Their literature in derm doesn't talk about a lot of the antioxidants that we know of. They're mainly focused on ascorbic acid because that's where their studies are. But vitamin C basically will make clinical improvements to photo damaged skin, and it's proven in studies. And it's also a cofactor in the biosynthesis of collagen and elastin and supportive of that process. So vitamin C not only is a free radical quencher, but it also participates in the production process of the ECM. So that's good. The other thing, glycolic acid, which is an alpha hydroxy acid, and any of the alpha hydroxy acids will perform the same function, but glycolic's kind of the best one. And it'll also basically stimulate more production of collagen in the dermis, and it improves the histologic quality of the elastin fibers. So again, that's supporting fibroblasts, that's supporting all of the things that we're looking to do in our treatment goals. Now there's peptides, such as copper peptide, GHK. It also can regulate fibroblasts and help to support them. So I'm a fan of that. We also have energy-based therapies. For example, heat actually can stimulate the dermis, and ablative techniques. So there's a lot of in-office techniques with lasers and laser resurfacing. They're very popular for collagen building and anti-aging, and these work. And then you have radio frequency use, and high intensity ultrasound even can do this to produce the elasticity in the skin and the neck. These are all things that have been done. And then we come to fillers. Now fillers I have mixed emotions about, but the fact is what you're doing when you're using a filler is you're basically using hyaluronic acid or some form of it or some similar substance, collagen-like substance, that's going to substitute for the ECM. And interestingly, fibroblasts will attach to this and grow in it. So the fillers can actually be populated by living cells. It's just not filler that you're pumping in there. It can actually begin to become part of the ECM if it's done well and done appropriately. So it does have a good role, but you can see there's many things we can do. But we can also see that it's a notable exception of a lot of the antioxidants that we use. So treatment options, here we go. Retinoids, tretinoin or adapalene are the two that you probably want to use. Tazarotene is really too strong for anti-aging use, even though it's a great retinoid. It's more like for other stronger purposes. Retinol is okay if you have tret sensitivity and can't tolerate retinoids, but it doesn't have the same effect. But retinol is good for people who can't use tretinoin because it irritates them, or they have some other pregnancy or some other reason why they can't use it. The dermatology is fairly limited to retinoids, ascorbic acid, but in these agents that I expand. I believe we can expand this to other antioxidants, polyphenols, thiols, nutraceuticals in some cases, and these guys could be topical or oral supplements. There's no reason oral curcumin might not help your acne patient. So in-office procedures also can be great. PRP and platelet lysate can directly stimulate skin, to produce more fibroblasts and stimulate those guys. Another big thing we haven't talked about is ceramides. Ceramides, and all lotions and creams aren't the same. CeraVe is unique in that it contains ceramides, which are the food that your skin actually is made of. It contains sphingolipids that are not synthesized by the body, and they can't be, and they can only actually be gotten through supplementation. So I'm a firm believer in topical nutritional supplementation, starting with ceramides, and CeraVe is the best thing I know about it. You can get more expensive stuff, but for the price of CeraVe, I don't know that you can beat it. Niacinamide is also a nice option in here to add, and we all know that hyaluronic acid is a big part of this. Hyaluronic acid is probably the most effective thing that you can do to make your patient's skin look better quickly. It is a glycose aminoglycan, and it is a part of the structure of the ECM. You're directly feeding the ECM, and it's just a very, very important item for anti-aging and appearance. And I mentioned before, fillers can artificially augment the ECM and provide a network. So fillers can play a part. And liposomal topicals that we can make can also have improved absorption to tissues due to the added transport mechanism of the liposomal delivery. So it's diffusion of the drug plus liposomal delivery. So that adds an additional effect. So that's looking at our treatment options. Now, treatment ideas. I like customized therapies for patients rather than have people put on 5 or 10 different things and switch them all up when they want to. I like the idea of having a single item that encompasses all of this. We have used, and many doctors have recommended to us, tretinoin, niacinamide, and hyaluronic acid. You can use a unique anti-aging vehicles if you want, and add some of these other nice agents. For example, vitamin C, vitamin E, ceramides, copper peptide, DMAE, other peptides can be used. You could use glycolic acid, sal acid, but if people can't take tretinoin, you can use either retinol or sal acid, which is what they call a beta hydroxy acid. And then nitromycin also has a unique vehicle that we developed that is really to boost nitric oxide in the body, but it contains a lot of interesting things that we can use in this area and have used. And there's a whole host of commercial and cosmetic items you can sell through your office that also do these things. So if you use these criteria to help select some products, that can also help. So one thing I did want to mention is topical nutraceuticals are not the same thing as emollients. Emollients are just fatty substance or an oil or petrolatum that you can put directly on the skin to prevent evaporation, but they don't feed the skin any nutrients. So I consider them totally different and both good, but not the same thing. So there's that. Now, Dr. Bill, I know we've gone on for an hour and a half. I got one more topic to cover. Should I continue, or would you like me to stop here?
How much more you got to go?
I think I can do it in 5 minutes.
Go for it.
All right, I'll go for it. Seborrheic dermatitis, guys, it's an easy one. Seborrheic dermatitis is a very common condition, okay? And we can treat it pretty easily too, but it requires a couple different medications. Subderm is a common condition, affects 25 to 50% and even higher in immunosuppressed patients. It's an inflammatory disease like psoriasis and a fungal infection is at the same time. As a fungal infection, subderm is caused by this Malassezia yeast, which is Pityrosporum. They've changed the name of Pityrosporum to Malassezia, but the condition hasn't changed, right? And it responds to treatments with antifungals, but there also is an underlying inflammatory condition. So Some view sebderm as a fungal infection. Some view sebderm as a chronic psoriasis-like condition that has a fungal component. So that the jury's out there. Now, how do you deal with it? Actually, it's pretty simple. You just need a treatment regimen. How do you diagnose it? I don't know if you use a KOH test, but with microscopy, but you use potassium hydroxide. It's just like the toenail fungus test, where you scrape the toenail and you put it in a little vial and you put the KOH in there, and then you can look at it under a microscope and you can see if there's fungi or yeast present. It'll stain them. So that's your diagnostic thing to separate it from psoriasis or something else. But you also may want to do testing on other things. The pathology isn't that well defined. Here's, according to AAD, it's disruption of skin microbiota, an immune reaction to Molluscum. Notice it's like rosacea in that the microorganism that's prominent is also triggering through endotoxin an immune response, which in this case is a diminished T cell response, and they call quote unquote activation of complement. So that is as far as dermatology usually seems to go into immunology. They'll just say it's an activation of complement. Well, it's quite clearly some kind of immune system event that we could better characterize. But they also know it's related to the increased presence of unsaturated fatty acids on the skin surface. Okay, disrupt, and that's what's feeding the fungi. Disruption of cutaneous neurotransmitters, that tells us there's an autonomic nervous system component that's not well discussed in the literature. Abnormal shedding of keratinocytes, we know that's happening because we see the skin sloughing. And then we have epidermal barrier disturbance associated with genetic factors. They're talking about filaggrin. Filaggrin is an important enzyme in the production of your skin barrier. And there are people who have a genetic inability, or their filaggrin doesn't work, and they don't produce functional filaggrin. So those people have a messed up skin barrier, and they are high candidates for this disease. So anyway, the Molluscum yeast includes degradation of sebum and all this business. We end up with a fungal infection of the skin. And what I'm showing here is the derm literature is more concerned with accurate differential diagnosis and physical symptoms than finding the root cause of the disease, because the root cause of the disease often lies outside of their specialty. That's a big point. So how do we handle subderm? And I think I have 2 more slides. So the subdermis usually presents along the hairline or back of the ears and neck. So I'll go back to the pictures. This is classic right here, the behind the ear. That is where you'll normally see it. Frequently, you'll see it like this too. And it's more or less common along the nose. In an African-American patient, you'll frequently see it along the hairline, like you see here. And then also you'll commonly see it around the chin and the mouth, like kind of in a circle around these areas. And that's classic seborrheic dermatitis. So how do we treat it? You need 2 or 3 different phases. You need a cleanser, which is your antifungal, okay? And that would be either ketoconazole shampoo or keto sal acid if you have plaques. That is a cleanser that you can use to wash the face, or you can use it as a shampoo for on the scalp, because subderm is common on the scalp. Topicals, basically we're going to combine an antifungal and a mild steroid. Now, oftentimes with antifungal treatments, we do not use steroids, and we don't normally want to, but you won't get your patient better very quickly if you do, and the patient will be unhappy. So usually to control a flare-up of subderm, you have to use steroids. But if you have a patient that's on maintenance, then you might try, if you can, to avoid the steroid entirely, or use a very mild steroid like hydrocortisone or desnide, or one that's approved for long-term use on the face. So that's your cast of characters there. Zinc Pyrothyron is also actually really effective for some people, but you almost always need the other agents. Now, if you're having a bad flare-up, you need a stronger steroid on the side, and that's usually betamethasone dipropionate, and they can apply that to the really bad lesions to get them under control. But as you know, the steroid's working against your fungal infection, so you don't want to do that too much. But in a nutshell, that's your recommended treatments for subderm, and that'll control almost every case if you kind of play whack-a-mole with it and get the patient on a routine. That's the key. And then you go through the risk factors a little bit. Anyway, I hope that encourages you to look at some of the dermatology conditions that your patients probably already have and that may be presenting to your office. It gives you another treatment option. And I also wanted to make sure that I clarified that, you know, the dermatology profession can need the help of regenerative medicine experts because some of the root causes of the illnesses they treat lie outside of their scope of practice. So I'll close with that. And any questions I can answer, I appreciate your attention.
Well, Mike, and you said you got another half to go.
I know, isn't that a long one? I'm sorry.
No, that's okay. I got a few questions in the chat. Will Amiculamod work if the immune system is compromised?
That's a good question. The answer is no. If it's slightly compromised, yes. But basically, if you have a patient and you use Amiculamod and you don't get much of a response or a slow response, that's an indicator that they do have immunosuppression. But so yes, that is correct. Amiculamod completely relies on the patient's intact immune system. So that would be a reason that you might have to use 5-FU in somebody.
Okay. Dr. Ortel is asking do you have a pre-printed order sheet for these types of therapies?
Oh, well, of course I do.
Okay.
Of course I do. Yep. And I'll forward that. Yeah.
Can you send it and we'll post it on our website and we can send it out to
and a lot of it's customized, but absolutely we have these things, and all these treatments can be compounded or handled with commercial products. And the problem with commercial products is they tend to add up. You get in the coupons and all the baloney that you have to go through to get them covered. Then you end up with a lot of problems. So sometimes compounding is the easiest and fastest way to get the job done and the cheapest. Yeah.
And funny you should say that, because the next question is Amiculamod cheaper if it's compounded?
That's a great question. It can be. The problem with the cost of Amiculamod is usually they can get it on a copay for say $40-50, but they get 3 grams of cream. So then they end up needing multiple refills that need prior auths or coverages and all that. So yeah, it's definitely cheaper for large application areas. So if you need 10 grams or 20 grams of Amiculamod, we would be less, very much lower in cost, unless the patient has really good insurance and they could get like 5 boxes of the packets or something like that.
Dr. Smith asks, do we need to check hormone levels if the patients have rosacea?
Absolutely, that's right, because that's kind of where I was going, is that these regenerative medicine techniques in the do you think the dermatologists are doing that? I doubt it.
No, they're not.
So yeah, they don't have your level of knowledge in this area. So I agree with that 100%. That's kind of one of my points. Yep.
And as a follow-up, what about naltrexone and low-dose naltrexone in a transdermal?
Well, yes. So we know that polarizes the immune system away from Th17, right? So if we have Th17 dominated disease like rosacea, then it would be reasonable to think that low-dose naltrexone would play a beneficial role. Yes.
Okay. Our usual attaboys from some of our participants.
Appreciate that. Yeah, absolutely.
Okay. Would methylene blue be beneficial and compounded with some other therapies?
I believe it does. It's a little bit drying. Okay, I've used it in our anti-aging products. I think, as you mentioned, methylene blue is a fantastic candidate for addition to an anti-aging regimen of skincare. As we know, it massively quenches free radicals and buffers oxidative stress. So absolutely, I believe that. One of the problems is methylene blue is blue, and we don't have to use very much of it. So you can do it at where it won't stain the skin or have any coloration. I have gotten that figured out. So it does happen. One of the downsides of using methylene blue topically, really the main one, is that the product can change color, because the methylene blue inside the product can, the product basically has more or less oxygen in it. So the methylene blue can be, cause the product to change color slightly. And so there's no way that I can get that out of it. So patients just need to be advised of that, but it doesn't mean it doesn't work or anything, or it's gone bad.
Okay. Anybody else have any questions or comments? I know it's getting on quarter, almost 20 of 10.
I know, and I apologize, everybody.
No, don't apologize. You're
my
great.
Second time to give this one, so I'll have to maybe make it the top 4.
Okay, I'm putting the conference, where to find the conference, aosrd.org/event. Click on that, and you will get to the conference website. Mike, we'll certainly want you back shortly. Next week, Dr. Rich Wine will be speaking on we're going back to our roots. We'll be discussing osteopathic medicine. Imagine that. Imagine that. Right. So we're going to look forward to that. He's going to talk about some old time treatment techniques, and it's something that we sort of emphasize again and again. We have Dr. Halassa coming back for a couple of his immunotherapies, and March 15th, don't miss it. Jacob Teitelbaum will be here on Tuesday night. We have Nathan Bryan, who lectures on nitric oxide. He'll be at the conference. He'll be here on a Tuesday night. So we have a lot of good stuff coming up. Please make an effort to support us in our efforts here. Las Vegas is a little bit more expensive than we're used to. We usually in Reno, so it is a little bit more expensive. If you have an email list of 50 or more, if you let us use it, we will give you a discount, guaranteed. There's a discount for being virtual online. And, we have a great lineup. We have, fabulous speakers. You would pay $2,500 minimum for this 3-day weekend from A4M. And it's 24 CME credits, category 1, AMA and AOA. So, and Las Vegas, it's on the Strip. And if you, right now it's March 3rd, the discount for the hotel is that's the deadline, but we're going to try to extend it. I think we'll be able to. It is less than it was $330 for me for 4 nights, and I'm staying Sunday night.
Yeah, that's amazing.
Clean up. So please make an effort to come and to support us. Anybody else have any questions, comments? The chat line looks good. Mike, a fabulous talk, and you can go on and on and on. And I'll chat with you later. We'll set up the second half. The last week in March, the first week in April is the earliest I have. Everything's booked to then. And for Mike, thank you, everybody. We'll see you in Vegas. Mike will be there. I hope to see you, and Dr. Spear will be there. Dr. Burgess is going to be virtual, I believe. I hope he can make it. And Dr. Ching, we want to see you, and Dr. Ortel and Dr. Smith. Dr. Cruz will be speaking for us. We have a couple of new names that I don't know. Bambi. I don't know who that is, but welcome.
Bambi, I'll introduce Bambi. He is the research and development pharmacist from Sands Pharmacy, our new 50-state partner.
Okay,
yes.
Great. Don't be a stranger. Dr. Patel will also be speaking virtually for us. And Dr. Aklavani is here every week. Thank you so much. We really appreciate it. Spread the word that we're here. We'll be here next week, same time, same station. Dr. Rich Wine will be speaking on osteopathic medicine. So we'll see you then.
Very good.
Okay.
Thank you, everybody.
This will be posted within 48 hours. Okay. Thank you so much.
Thank you, Dr. Bill. Have a great night.
Okay, John. Anything else we need to go over? Nope. Okay. All right. Thank you, everybody.
Bye-bye.
Bye-bye.